So, I finished my fellowship in 1995 in Gyn Oncology. And really, there hadn't been many advances made in trying to screen women for ovarian cancer until I'd say within the last year or so. And I think it's a huge advancement that we've made. My only disclosure, I have no financial disclosures, but my only disclosure is I am a gynecologic oncologist. If we look at cancer death rates in women in the US between 1930 to 2006, several things actually become very obvious. The first thing is that the survival rate or death rate among women with ovarian cancer has remained relatively flat. There hasn't been much change, and that really speaks to the fact that we don't have a good screening test. Women present with advanced stage disease, and even though they have an excellent response to initial treatment or therapy, what ends up happening is that they have recurrences, and then once recurrent, they die of their disease ultimately. So we've done a great job of prolonging life, improving survival in terms of the number of years that they survive, but we've done little to actually cure them of their cancer. Where if you look at diseases like colorectal cancer, you can see that there's been an improvement, breast cancer, and that really speaks to the fact that we have excellent screening modalities. We have colonoscopies, we have mammography, and that's really made a huge impact. And so we're always looking for that elusive screening test. Well, how can we improve survival? Well, probably the best thing that we can do right now is diagnose disease earlier. So we know that by diagnosing disease earlier, we markedly improve survival. Women diagnosed with stage 1 ovarian cancer have greater than 90% survival rate. With those who are diagnosed with stage 3, it's only 15% at 5 years, and stage 4 is only 5%. So you can see that earlier diagnosis is really important. The other thing about making an early diagnosis is that it assures appropriate surgical management. And it's been clearly identified in multiple studies that the involvement of a GYN oncologist in the surgical management of a woman with ovarian cancer is crucial for many reasons. It not only assures that the proper procedure is performed, but it also is a higher likelihood of having optimal cytoreduction. And even with a GYN oncologist involved in the surgical procedure, we do about 50-50. Now, if you look at some of the studies that came out of California, with Nick Spirtos, they'll tell you that they have greater than 90% cytoreduction rates. But if you really look at the studies from across the country, it's about 50-50. The other thing that's really come out of this is that multidisciplinary teams and hospitals with high volumes have better outcomes for their patients. And lastly, if we're able to diagnose an ovarian cancer at an earlier stage, it's going to prevent the delay in definitive treatment and management. So Mercado actually looked at women who were diagnosed with ovarian cancer between 1991 to 2004. And this was in New York, California, Florida, Washington. So these are actually states that we have a very high concentration of GYN oncologists practicing. And what they looked at is they looked at who actually performed surgery for these women. Were there a gynecologist or GYN oncologist involved, or a general surgeon or some other surgical subspecialist? And they looked at 3 outcomes: surgery by specialist type, receipt of an ostomy. And that receipt of the ostomy really was how they kind of identified whether or not quality of life was impacted. Because all of us know that as soon as you tell a woman, whenever I'm consenting somebody for surgery, and I tell them that a colostomy is a possibility, they automatically get very teary-eyed, start shaking, and say, "You got to be kidding me." And I think that's probably one of the hardest things. They accept going through menopause if they're premenopausal. They accept the big surgical incision. It's the ostomy that always throws them. And then they also looked at time of death. So he had 31,000 women who met inclusion for criteria. 57% were operated on by a GYN oncologist or gynecologist. Across the country, only approximately 47% of women with ovarian cancer are operated on by a GYN oncologist. Those women who were more likely to have surgery by a general surgeon were hospitals that had low volume, which you would expect. There's oftentimes not GYN oncologists practicing in those settings, and also below the poverty line. Greater likelihood of an ostomy was performed by a general surgeon, and I don't think that's because they're callous or lazy or don't want to take the extra time. I think it's really because for the surgical procedures that they perform and for what they do, ostomies are indicated. They're managing patients with colorectal cancers, and those tumors in many, many situations require the placement of an ostomy. They don't understand that in GYN oncology, you don't need the big margins that they have. They don't understand that tumors can be peeled off of the colon or bowel. And so with general surgery, they're more likely to place an ostomy. And as you can expect, quality of life goes down. They found that survival was better in higher volume hospitals, and that survival was better with the involvement of a GYN oncologist. And these results have pretty much been borne out in multiple studies and settings. So the SGO, which is the Society of Gynecologic Oncologists, actually came up with their management statement in 2000 saying that board-certified GYN oncologists are best trained to treat malignant or suspected malignant GYN conditions. Now, the NIH in 1995 convened a consensus panel, and they pretty much reached the same conclusion. And part of the reasons why they really felt that the GYN oncologist was a necessary component of the care of women with ovarian cancer was that it lessened the need for multiple surgeons. There was not a need to take somebody back to the operating room if they had an ovarian cancer diagnosed inadvertently. And it really resulted in cost-effective patient management. So if I look at this, how is a patient or a woman with ovarian cancer or an adnexal mass going to be referred to me? And they're really going to be picked up one of several ways. They're either going to be screened or in some kind of screening regimen, and that's how it's going to be diagnosed. They're symptomatic, which to me is the most concerning scenario that I see in my office. When I have somebody who's symptomatic, I automatically assume they have ovarian cancer until proven otherwise. They're either going to be diagnosed on routine pelvic examination, of which all of us could say that rarely happens, or it's going to be an inadvertent finding on imaging performed for an alternate reason. And that's where you're going to get those referrals for somebody who had back pain and they had an MRI, or they had a CT scan, or they had abdominal pain, and there was this finding in the adnexa. So let's look at screening first. So based on the NIH Consensus Conference, it said that there were no available current screening modalities, which in 1995 was pretty much just CA125 and transvaginal ultrasound, that can be used effectively. And you have to understand the purpose of screening tests are to reduce mortality and not result in increased morbidity. Now, it's very hard to develop an ovarian cancer screening test because, one, very few women are diagnosed with ovarian cancer. It's only approximately 50 per 100,000. And to have a really effective screening test, you need to have a test that has a positive predictive value of 10% and a specificity of 99%, which is very difficult to do. So what they ended up saying was that the only women who should undergo screening are those who are presumed to have hereditary syndromes. Okay, now this was pre-BRCA. Now we have BRCA, so that would be one of the indications, but this was just any woman with a strong family history should undergo CA125 and transvaginal ultrasounds, and at the age of 35 or after childbearing is completed, undergo a prophylactic oophorectomy. So the NCCN guidelines actually advise women to undergo genetic testing because many times women's perception of what their actual risk is far greater than what their reality of their risk is. For those women who are at risk or for women who are BRCA positive, there's recommendations for 6-month screening with CA125s and transvaginal ultrasounds, but they're very clear to state that there's evidence lacking improved survival benefit. And there's currently 2 studies that are almost completed and their results should be published shortly. One is the prostate, lung, and colorectal ovarian cancer, or the PLCO trial, which looked at sonography and CA125s, trying to determine whether or not routine screening could identify women who are at risk. And the other one is out of the UK, and it's a collaborative ovarian cancer screening trial. And that may actually, hopefully, put to rest whether or not is this a screening modality that we can use. The other thing that they say is that there's strong consideration needs to be given to prophylactic oophorectomy, again, using that magic cutoff of 35 to 40, or after the completion of childbearing. One of the things you need to keep in mind is that if you have a woman walk into your office and all of the members in her family were diagnosed with ovarian cancer at the age of 30, well, if you wait to 35 or 40, it's going to be too late. And so usually what we recommend is approximately 5 years before the age of diagnosis of the youngest member in their family. That's when they should undergo their surgical procedure. Well, how come we can't find this elusive lesion that's seen on ultrasound? Well, the first thing is that ovarian cancers are very heterogeneous. We have tumors that are low malignant potential tumors, we have high-grade tumors, we have tumors that are very metastatic, but we've never been able to find what is that pre-malignant ovarian cancer lesion. There are numerous studies that have suggested that it's epithelial inclusion cysts, cortical invaginations, papillomatosis, stromal cell activity, but it's never been able to clearly be identified what is the pre-malignant lesion. It was only after we started identifying women who are BRCA1 or 2 positive and they started undergoing oophorectomies, prophylactic oophorectomies and salpingectomies, that we actually started to understand a little bit better what's going on. The first thing that we found is that there were no differences in the ovaries of the women who are BRCA1 or 2 positive versus women who are BRCA negative and undergoing oophorectomy for other reasons. But what actually was seen is that the women who were BRCA positive had marked changes in the fallopian tube. And based upon which study you read, it can either be that 57 to even up to 100% of women who undergo these prophylactic bilateral salpingo-oophorectomies have changes in the fallopian tube which predispose them to developing high-grade cancers. Kerman was actually the first person who started to suggest that perhaps ovarian cancer falls into 2 subgroups or subtypes. Type 1 is slow-growing, generally confined to the ovary at diagnosis, developing from well-established precursor lesions. Those are going to be your low-grade micropapillary serous carcinomas, your mucinous, and clear cell. Whereas the type 2 are usually rapidly growing, highly aggressive neoplasms, not coming from a precursor lesion, and those are the high-grade serous carcinomas. So Crum did a very nice model of this. The bottom schematic, or the ovarian or peritoneal surface, is pretty much the way that we were all taught that ovarian cancer develops, and that actually would fit with the theory of incessant ovulation. So a transformation occurs in cells that are either in the inclusion cyst or endometriotic lesions. They develop into a low-grade cancer, and then through a variety of genotypic and cellular type changes, develop into carcinoma. Whereas the alternative theory, which we know from the BSO specimens of the BRCA positive patients, is that these patients who have high risk factors are actually developing changes in the fallopian tube. And these are all due to p53 changes. And you can either see what's called the p53 signature, which is just they have mutant p53, or associated with normal mucosa, an in situ type lesion, or STIC, and through a series of genotoxic injury, unregulated cell growth, which is where the p53 comes in, develops into a metastatic phenotype, and that invasive lesion develops in the fallopian tube. Well, you can imagine that that has huge implications in terms of developing a screening test for ovarian cancer, because we know that we're not going to be able to see a marked abnormality in a fallopian tube. And how long is that going to be? That fallopian tube is actually exposed to the abdominal cavity. when do metastatic lesions develop? Is it already too late? Is the horse out of the barn if we already have a lesion in that fimbriated end of the fallopian tube? And so this actually has huge implications in terms of screening for ovarian cancer. Fallon's actually looked at the two pathways. The ovarian pathway is what we have normally thought about. So you find that high BMI, hormonal factors, so those are the women who have multiple ovulatory cycles. They're going to end up with the low-grade endometrioid tumors. And those tumors are usually going to be KRAS, BRAF, PTEN positive. Whereas the tubal pathway, or that BRCA positive pathway, is more likely going to have the P53 signature, have a low or normal BMI, and it's going to be due to this P53 mutation and genotoxic injury that they develop cancer. So ultrasound screening really is going to have limited value with this new proposed pathway for development of ovarian cancer. And so really, if we detect women with abnormalities on ultrasound, are we really only finding those women who have earlier stage, less aggressive tumors and are going to have a better survival? And that's why it's very crucial that we identify biomarkers which can predict or show signatures either through proteomic or genomic profiling that can help us identify genetic alterations which we can use for screening so that we can develop testing that will enable us to detect a woman's ovarian cancer before it metastasizes. So looking at that proteomic pathway, Ratner out of Yale found that KRAS mutations, and KRAS is involved in the MAP kinase growth pathway, was associated with an increased risk of ovarian cancer. They found that KRAS mutations were present in over 25% of patients, and they were strongly associated with the hereditary breast ovarian cancer families. Now, interestingly enough, if you think back to the prior slide, Fallon's actually showed that KRAS mutations were more commonly seen in patients who had low-grade mutations. So why is it that these women who are segregating out with this high-risk group are going to be KRAS positive? But they found that KRAS was associated in 61% of women tested. And not only that, it's segregated with family members who were also diagnosed with cancer. And they proposed that this KRAS variant was a genetic marker and may account for genetic risk in women with familial histories that were BRCA1 and 2 positive. Well, they actually developed a test. It's called PreOvar. It's marketed through Mira Diagnostics. And the test is marketed based on the fact that it was done to identify ovarian cancer patients whose female relatives could be diagnosed or tested for this KRAS variant, especially if the patient with ovarian cancer was BRCA1 or 2 negative. It may actually help assess the relative risk of developing ovarian cancer in a woman with a family history of ovarian cancer without a living relative who could be tested for the mutation. And that it was present in over 60% of hereditary breast ovarian cancer patients previously classified with uninformative or negative genetic mutations on a BRCA1 or 2 test. So again, trying to help us identify whether or not we could identify women who are at risk prior to the development of ovarian cancer. So the Society of Gynecologic Oncologists released a statement saying that they understand that this is a huge issue and problem, that there's benefit and potential utility to determining ovarian cancer risk with these assessment tests, and that at this time, the clinical value of the PreOvar test remained unknown, and that further validation studies needed to be performed before it could be recommended as a diagnostic or screen tool for ovarian cancer risk. Well, Burchuk actually decided that he was going to look at this, and so Andy, at the March 2011 SGO meeting, presented a evaluation of this KRAS mutation using a very large sample size of samples that had been obtained from 2 tissue banks. He had over 9,000 ovarian cancer cases and 12,000 controls. And the objectives of the trial were to validate the results of the prior study that was published by Ratner, examine the exact association of this KRAS SNP, or single nucleotide polymorphism, with ovarian cancer risk, and see whether or not it could be associated with family history or BRCA positivity, and then try to associate it with progression-free and overall survival. So what Burchuk did actually was that he found that there was no association between the KRAS SNP, the risk of epithelial ovarian cancer, serous epithelial ovarian cancer, familial epithelial ovarian cancer, or BRCA mutations. Overall risk were almost 1. And he found that there was a little association with survival. And so therefore, his conclusion with this large sample size was that the use of the SNP clinically for ovarian cancer risk prediction is unwarranted. I had never used it in my clinical practice. We have a very well-established high-risk clinic at the Cancer Institute, and our collaborative decision had been that we were not going to use pre-OVAR, and we're still not using it. The makers of pre-OVAR actually argue that Burchuk's results are flawed, that they're different patient populations, and I think that it's going to be very hard to recover from this study, and I think that we don't have enough information at this time to warrant the use of pre-OVAR in testing, but that if it's going to be evaluated, it needs to be done in the research setting. All right, so what about symptomatic women? So Barbara Goff actually was the first person who really showed that women with ovarian cancer are symptomatic regardless of whether they have early stage or late stage disease. And she did this by surveying a group of women who were subscribers to this grassroots ovarian cancer newspaper called Conversations. And approximately 1,500 women answered this survey. The median age was 52. 71% at the time of diagnosis had stage 3-4 disease. Only 5% of patients denied symptoms prior to diagnosis. So, and 11% was stage 1 or 2, and 3% of stage 3-4. So you can see that women are symptomatic. An incorrect diagnosis was associated with delay, as you can imagine, and women were told they had everything from stress to depression to irritable bowel syndrome, or there's nothing wrong with you, go home. 33% of responders saw 3 or more practitioners. So this is where that ability to identify somebody who does have cancer plays a huge part. And the ovarian cancer symptom consensus statement was released in 2007, hoping that through education of not only women, but also practitioners, not necessarily gynecologists or individuals in this room, that if we make them aware that symptoms do exist with ovarian cancer, we're actually going to be able to identify disease at an earlier stage. And the symptoms that are associated with an increased risk are bloating, pelvic or abdominal pain, difficulty eating, or early satiety, and urinary symptoms. And the first 3 are actually independently associated with it. Any symptoms that are persistent and represent a change for the patient requires further imaging or referral to a gynecologist. And anything that lasts for more than 2 or 3 weeks requires evaluation as well. So hopefully with education, we're going to be able to get women into the doctor sooner. Well, what about those masses that diagnosed on routine examination or an inadvertent finding on imaging? So we know what our imaging is. We have transvaginal ultrasound. I'm not recommending, we have MRI, and PET or CT scan. I am not recommending using PET or CT scan imaging for evaluation of adnexal masses, but we're probably all very well aware that a lot of times these are the women that are getting referred to us, and we have to try to figure out what's going on. And the biomarkers that we have are really CA125 and the 2 new ones, which are HE4 and the new test called Ova1. So if we look at the modalities that we have available for evaluation of adnexal masses, we see that Ultrasonography, and really Doppler ultrasonography, has the best sensitivity and specificity at 86 and 91%. That CT scans, while they're sensitive, can detect 90% of masses, only have a specificity of 75%. And that CA125 down at the bottom is about 78% for sensitivity and specificity. What I use MRI for is for those women who come into my office who I'm really fairly certain that they don't have ovarian cancer, but they have findings on their ultrasound that suggest they either have calcifications or a solid component to their ovarian cystic mass. And I use the MRI to rule out or determine whether or not that I think that area is malignant. And it actually is very helpful in many situations. For those patients who have low-risk imaging, we just follow with ultrasonography, and those women who have something concerning go to the operating room. PET scans are not a good modality for screening. If you have somebody referred to you who's postmenopausal with a positive PET scan that lights up, that isn't a cancer until proven otherwise. But in that premenopausal patient, there are a lot of false negatives, false positives. So hydrosalpinges, pedunculated fibroids. If they're in the late follicular, earlier luteal phase, they can light up. So you have to be very careful when you're looking at PET scan imaging that you actually correlate it with the menstrual cycle. There's also a lot of false negatives. So early stage cancers and low-grade tumors oftentimes will not be PET positive. So what tests do you routinely order to help evaluate patients with an adnexal mass in addition to ultrasonography? CA125, Ova1, HE4, CA125 and Ova1, CA125 and HE4, CA125, Ova1 and HE4. And I don't know if you have 7 clicker spots, but ultrasonography alone. Okay, so the majority of us order CA125 level alone, which I think would probably be across the country. 2 people are very progressive. They're ordering Ova1. And 1 person orders CA125 and I don't even remember which one I put there, and Ova1. Okay, good. Okay. Well, I'm not going to spend a lot of time on CA125. We all know it's a glycoprotein, a monoclonal antibody directed against a glycoprotein. Elevations are seen oftentimes 1 year prior to the diagnosis of ovarian cancer. So that's why it's very important to follow these women. If you have somebody in your practice who you've been following who's at risk, and they had a CA125 level that ran in the 10 to 15 range, and they come back in and your normal cutoff in your lab is 35 and they come in at 34, and you did it on the 3rd day of the menstrual cycle, and that would be somebody who I would go, a flag should go off in your head. That's a change over their baseline, and that needs to be further evaluated. I would bring them back in, repeat the CA125 level, and proceed from there to see whether or not it's a false positive. Many times the limitations are that only 80% of tumors express CA125. We know that only women with 50 to 60% with stage 1 disease have a positive screen, and that there are variations with the menopausal status. So that led to HE4. HE4 is human epididymis protein 4, which would make no sense why it should be in the ovary, but it is. It's a glycoprotein that was identified in tissue microarrays of women with ovarian cancer, and it's expressed in ovarian cortical inclusion cysts. It appears that it's a marker of Müllerian differentiation and not neoplastic transformation. Variations are seen with the menstrual cycle, increased levels are seen with menopause. It's expressed in serous, endometrioid, and clear cell cancers, and it's been approved by the FDA only for monitoring women with ovarian cancer. It is not considered a screening test. HE4 is expressed in fallopian tubes, endometrium, endocervix, respiratory epithelium, and of course the epididymis, which really doesn't matter to us. And occasionally staining can also be seen in salivary glands and epithelium of the renal convoluted tubules. So again, not expressed in the ovary. Normal value ranges vary. If you look at Brown's handout, it's less than 115. I've seen other levels of 70 used. But the thing that's most significant is a change of greater than or equal to 25%. It's not effective in screening or management of mucinous tumors. It's not expressed in mucinous tumors of the ovary and cannot be used for evaluation of germ cell tumors. It's not elevated with endometriosis, which is a huge help. And it's elevated in over 50% of patients who have a normal CA125 and a diagnosis of ovarian cancer. So there may be a niche group of women who may benefit from this. Has greater sensitivity in early stage disease than CA125 alone. So Moore actually tried to say, well, it's been approved for the monitoring of ovarian cancer. Can we use it as a screening test? And this was a prospective multicenter study in women who already were diagnosed with an adnexal mass greater than the age of 18 undergoing surgery. What he was trying to do was validate a model using HE4 and CA125 and try to identify or segregate women into low and high risk groups. Women were referred for surgery or were having surgery, so there was no consistency in terms of radiographic imaging. The blood samples were obtained preoperatively, the physicians were blinded to the results, and there was central pathology review, which is a strength of the study. So looking at how effective the combination of the two tests are, if you look at the low-risk group, that would be the false negatives, 17 patients, or 6.1%, were diagnosed with cancer and were segregated into the low-risk group, whereas 60% in the combined menopausal status arm were found to have high risk and were actually confirmed to have ovarian cancer. We can see that it was actually not bad using the two combination of the two in terms of finding premenopausal and postmenopausal tumors. Only 8 women were categorized as low risk in the premenopausal group who had ovarian cancer and 9 in the postmenopausal group. So it had a sensitivity of 92% and a specificity of 74% in that postmenopausal group, and in the premenopausal group for about 77 and 75%. So about the same as what CA125 alone was. So in 2009, Quest Diagnostics actually released Ova1. And Ova1 has FDA approval for a very specific indication. It is only to be used in women who have been found to have an adnexal mass, who are undergoing surgery, and it is to be utilized as a mechanism to determine whether or not women should be referred to a GYN oncologist. It is not a screening test. And that's very, very important because we're not going to expect the same results utilizing Ova1 as we would with a screening test. It can only be utilized in women who are over 18. And what Ova1 does is it actually looks at 5 biomarkers: apolipoprotein A1, beta-2 microglobulin, CA125, hormone and vitamin transthyretin, and transferrin. And the beta-2 microglobulin and the CA125 are upregulated, the other 3 are downregulated, and it uses a calculation to determine a result. So it's not a standalone diagnostic test. It really is to be utilized in combination with your clinical evaluation and judgment. A negative test in the setting of what you think may be ovarian cancer does not preclude you from referring somebody to a GYN oncologist. Triglycerides greater than 4.5 grams per liter may interfere with the test. And it's not to determine whether or not surgery is necessary. The criteria that referrals should be initiated in a premenopausal patient if the level is 5, and in a postmenopausal patient if the level is 4.4. So just recently, just about a month ago, if even that, Uland actually released, there have been 2 studies that have actually been done. We're going to talk about both. We're going to talk about this one first. This actually compared Ova1 which is called the MIA, multivariate something assay. I can't believe I blanked on the I. But it doesn't matter, it's Ova1. And what they did was they compared MD assessment to Ova1 in trying to identify women with high-risk cancers. It was a multicenter prospective trial. The physicians who participated were generalists as well as GYN oncologists, and all women entered on study had to be scheduled to undergo surgery within 3 months from that time of diagnosis. Laboratory assessment was done preoperatively, and pre-op physicians were to determine whether or not they thought the mass that was going to be removed was malignant or not. There were 151 ovarian cancers diagnosed. 94 of them had epithelial ovarian cancers. 11 were non-epithelial, 28 were borderline, and 18 were metastatic. So utilizing our CA125 criteria, using the ACOG guidelines for premenopausal patients, anybody who's postmenopausal who has a CA125 level greater than 35, if that's the cutoff of your lab, or 20 if that's the cutoff of your lab, should be referred for evaluation to a GYN oncologist. But for that premenopausal patient, the ACOG guidelines really say 200 is the cutoff for a premenopausal patient for referral. And then we're going to discuss Deer-King's study results in a few minutes, but that actually used a cutoff of 67. So we see that CA125 alone has about the same sensitivity and specificity that's published in all the trials, about 77 and 69, 77 and 73 if you use the Deer-King results, and 69 and 84 if you use the standard ACOG criteria. Ova1 had a sensitivity of 93%, a specificity of 43%, and you can find that actually it did better than physicians who had a 75 and 79%. But using Ova1 in combination with MD assessment actually increased the sensitivity to 96% and a specificity 35%. So much better than either alone. Adding the Ova1 to the MD assessment correctly identified 70% of malignancies that were missed by non-GYN oncologists, which is really the purpose of the test. We're not screening, we're trying to detect cancers early. As a consequence, though, because of that specificity, the benign tumor referral rate is 72%. So many more patients are being referred. Despite the correct physician assessment, 45% of patients with benign tumors were referred for surgical management by a GYN oncologist. And Ova1 identified 76% of malignancies missed by CA125 alone. 82% of malignancies missed by MD assessment were picked up by Ova1 and in combination. And 86% of those malignancies would have been missed by CA125. So this test actually did achieve its goals. It was referring women earlier to a GYN oncologist. And one of the things that it really pans out is that, if we utilize that cutoff point of 4.4 for the postmenopausal woman and 5 for the premenopausal woman, we can see that the percentage of malignancies is lower. But as the test results increase in terms of value from anywhere from 6, 7, 8, 9, we can find that the percentage of malignancies increase. So if you have a test result that's much higher, your higher likelihood is that you do have a woman with ovarian cancer. So what algorithms are available to help us determine whether or not somebody has cancer? So the RMI, or Risk of Malignancy Index, was actually proposed by Ian Jacobs in 1990. And in a meta-analysis in 2009, it has been found to be the most effective algorithm utilized to identify women with ovarian cancer. It's based upon architectural findings on ultrasound, CA125, and menopausal status. And based on whether you use a score of 200 or 50, you actually can have a sensitivity ranging from 95% and a specificity of 76% for that score of 50, or 85 and 96 for that score of 200. It's an easy formula to use. You calculate your ultrasound findings by your menopausal status and your CA125 level. Ultrasound is scored 1 point for each of those criteria there. You total up your ultrasound score. If you have 0 or 1, you're given a score of 1. If you have a score of 2 to 5 points, you're given a score of 3, so you would put 3 in the ultrasound box. If you're postmenopausal, you're 3, and then you multiply out your CA125 value, and that can help you determine whether or not your patient has cancer. So since Jacobs first published this in 1990, there have been multiple results, other studies that have looked at it. Usually in 1990, Jacobs actually gave an ultrasound score of 0, so that would be a woman who had a unilocular cyst. You could see that it would kind of throw the whole result off because you'll get a value of 0, and that wouldn't refer anybody. So that's when Tingelstad actually proposed that that ultrasound score of 0 should actually be a 1, and that actually improved the test accuracy. Yamamoto in 2009 took the findings and actually said, well, we should add tumor size into it, but that has not been validated in a prospective study. So pretty much we're still using the original proposal of RMI based on Jacobs. So always looking to do better. The ROMA, which is the risk of malignancy algorithm, has recently been suggested. This study, the risk of malignancy algorithm, actually utilizes CA125, HE4, and menopausal status. So it gives us a little bit more objective results to help us determine whether or not somebody has cancer. And this study was actually undertaken to try to validate ROMA as a predictive model. Blood work was performed preoperatively. It was a multicenter study. Imaging was reviewed by 3 reviewers, and 566 patients were enrolled, of which 457 were evaluable. So if we look at the early stage group, which is the group we really want to target, we find that ROMA compared to RMI had a sensitivity of 85.3% compared to 64.7% for the risk of malignancy index. So, and for advanced stage disease, it was 98.8%. So I think that we're going to be hearing a little bit more about ROMA in the future, and that this is actually the first step in trying to further validate this as a new algorithm for use. So what are our treatment or referral guidelines? Well, the ACOG committee opinion just actually got recently released in 2011. It had been the same one since 2002. It changed from 280 to committee opinion 477. Pretty much didn't change much. For women with postmenopausal disease, anybody with an elevated CA125 greater than 35 or 20, if that's your lab, ascites, a nodular or fixed pelvic mass, and evidence of abdominal or distant mets needs to be referred. And women who are premenopausal, a value of a CA125 level greater than 200, ascites, and evidence of abdominal or distant mets. It used to be that there was criteria in there that if you had a strong family history, you needed to be referred, and that was removed based upon the results of Deer King. So Deer King actually undertook a 5-year prospective study at the Mayo Clinic where he enrolled women who were premenopausal and postmenopausal who were referred for evaluation of Adnexal mass. The postmenopausal evaluation guidelines had a sensitivity of 93%, a specificity of 59 or approximately 60%, and a positive predictive value of about 65%. Again, as you would expect, the premenopausal guidelines were only 79% sensitive and 69% specific. Mayo Clinic has a very unique setup. They have a very well-established GYN group in addition to a Gyn Oncology group. So their GYN group actually is a feeder group to the Gyn Oncology group. There's not really a referral base outside of the university setting. So it's a little bit of a unique patient population, which probably changed some of the results. But what they found was that 28 patients were not referred based upon guidelines. 11 out of 14 cancers in postmenopausal patients, and 8 out of 10 in premenopausal patients with early stage disease. But what he actually found was that if you decrease the CA125 level in premenopausal patients to 67, you do better. And he recommended dropping family history because it really didn't make any impact in terms of results. And that the guidelines were not adequate in determining early stage disease. So Ova1 then said, okay, well, let's look at Ova1 versus CA125 utilizing the ACOG guidelines in determining whether or not Ova1 is a better referral mechanism. So this was a prospective study, confirmation by imaging. Again, this was not a screening test, so the radiographic imaging's across the board. You had to be 18 years or older with surgery within 3 months. And the statistics were stratified based upon menopausal status, stage, and pathology. So let's look at the early stage group, because that's really the group we care the most about. We see that the ACOG guidelines alone had a sensitivity of 47 and a specificity of 77%, which is about what Deer King found. But if we added the Ova1 test to the ACOG guidelines, we actually improved that sensitivity and specificity from up to 88 and 43%. And in postmenopausal women, to 100% and 26%. So much better test than probably the ACOG guidelines alone, but again, a greater percentage of patients being referred for early stage disease. The college guidelines with Ova1 correctly identified 78% of those missed premenopausal malignancies and 100% of the missed postmenopausal malignancies, and was able, with the college guidelines, to detect 93% of premenopausal and 100% of postmenopausal primary ovarian malignancies. So again, a better test to try to help physicians determine whether or not referrals should be initiated. So where do I stand on all of these testing results? I think that it's actually very exciting that we actually have options now. I think that Ova1 is going to hopefully enable a greater percentage of women to make their way to the GYN oncologist and have that appropriate surgical procedure and not have their a delay in diagnosis. My concern is that when you see that, and I should have asked this question, which I didn't, but if you, just out of curiosity, if you had a patient who you thought had benign disease but had a positive Ova1 screen, would you keep the patient in your practice and operate, or would you refer out because you were concerned that you may be sued if the patient ended up having a cancer? So how many of you would still operate on that individual? How many physicians would refer out? And that was actually my discussion that I had yesterday. My concern is that these tests are all great, and I think that what it's doing, it's helping women. But my concern is that there's going to be a glut of women that are now going to GYN oncologists, and there's only so many of us in this country. And if we are doing more surgical procedures, how do we balance, who is benign and who is cancer? If I have somebody who refers into me and they say, well, I have a positive Ova1 test, I don't think she has cancer, and I say, no, go ahead and do the surgery, and you're going to go, I don't want to touch her. Why are you sending her back to me? I sent her to you already. And that's my concern. So I think that it's a great test in terms of it's probably going to identify women who need to be referred. I just don't think we know how it's going to pan out clinically. And I think we need to see what we're going to do with it in the future. I don't think that HE4 at this time should be utilized as a screening test. It may be a good test if you're kind of in that awkward situation that you don't know what to do. But again, I think at this time we still need a little bit more information before we can clearly say this is the right way to go or this is not the right way to go. But I think that we have great options now, and I think that at least we've made advancements where it's been relatively stagnant for several decades.